don't stop. Don't stop. Don't stop. Don't stop. Don't.
Joints of upper limb. Introduction joints are sites where two or more bones or cartilages articulate. Free movements occur at the synovial joints. Shoulder joint is the most freely mobile joint. Shoulder joint gets excessive mobility at the cost of its own stability, since both are not feasible to the same degree. The carrying angle in relation to elbow joint is to facilitate carrying objects like buckets without hitting the pelvis. Supination and pronation are basic movements for the survival of human being. During pronation the food is picked and by supination it is put at the right place, the mouth. While giving, one pronates, while getting one supinates. The first carpometacarpal joint allows movements of opposition of thumb with the fingers for picking up or holding things. Thumb is the most important digit. Remember. Shoulder girdle. The shoulder girdle connects the upper limb to the axial skeleton. It consists of the clavicle and the scapula. Anteriorly, the clavicle reaches the sternum and articulates with it at the sternoclavicular joint. The clavicle and the scapula are united to each other at the acromioclavicular joint. The scapula is not connected to the axial skeleton directly, but is attached to it through muscles. The clavicle and the scapula have been studied in Chapter 2. The joints of the shoulder girdle are described below. Sternoclavicular joint. Dissection. Remove the subclavius muscle from first rib at its attachment with its costal cartilage. Identify the costoclavicular ligament. Define the sternoclavicular joint and clean the anterior and superior surfaces of the capsule of this joint. Cut carefully through the joint to expose the intra-articular disc positioned between the clavicle and the sternum. The fibrocartilaginous disc divides the joint cavity into a superomedial and an inferolateral components. Features. The sternoclavicular joint is a synovial joint. It is a compound joint as there are three elements taking part in it, namely the medial end of the clavicle, the clavicular notch of the manubrium sterni, and the upper surface of the first costal cartilage. It is a complex joint as its cavity is subdivided into two compartments, superomedial and inferolateral B and intra-articular disc, Fig 10.1. The articular surface of the clavicle is covered with fibrocartilage, as the clavicle is a membrane bone. The surface is convex from above downwards and slightly concave from front to back. The sternal surface is smaller than the clavicular surface. It has a reciprocal convexity and concavity. Because of the concavo-convex shape of the articular surfaces, the joint can be classified as a saddle joint. The capsular ligament is attached laterally to the margins of the clavicular articular surface, and medially to the margins of the articular areas on the sternum and on the first costal cartilage. It is strong anteriorly and posteriorly where it constitutes the anterior and posterior sternoclavicular ligaments. However, the main bond of union at this joint is the articular disc. The disc is attached laterally to the clavicle on a rough area above and posterior to the articular area for the sternum. Inferiorly, the disc is attached to the sternum and to the first costal cartilage at their junction. Anteriorly and posteriorly the disc fuses with the capsule. There are two other ligaments associated with this joint. The interclavicular ligament passes between the sternal ends of the right and left clavicles, some of its fibers being attached to the upper border of the manubrium sterni, Fig 10.1. The costoclavicular ligament is attached above to the rough area on the inferior aspect of the medial end of the clavicle. Inferiorly, it is attached to the first costal cartilage and to the first rib. It consists of anterior and posterior laminae. Blood supply, internal thoracic and suprascapular arteries. Nerve supply, medial supraclavicular nerve. Movements of the sternoclavicular joint can be best understood by visualizing the movement at the lateral end of clavicle. These movements are elevation/depression, protraction/retraction and anterior and posterior rotation of the clavicle. The anterior and posterior rotation of clavicle is utilized in overhead movements of the shoulder girdle. Acromioclavicular joint. Dissection. Remove the muscles attached to the lateral end of clavicle and acromial process of scapula. Define the articular capsule surrounding the joint. Cut through the capsule to identify the intra-articular disc. Look for the strong coracoclavicular ligament. Features. The acromioclavicular joint is a plain synovial joint. It is formed by articulation of small facets present at the lateral end of the clavicle, on the medial margin of the acromion process of the scapula. The facets are covered with fibrocartilage. The cavity of the joint is subdivided by an articular disc which may have perforation in it, Fig 10.1. The bones are held together by a fibrous capsule and by the articular disc. However, the main bond of union between the scapula and the clavicle is the coracoclavicular ligament described below, Fig 10.1. Blood saply suprascapular and thoracoacromial arteries. Nerve supply, lateral supraclavular nerve. Movements, see movements of shoulder girdle. Coracoclavicular ligament. The ligament consists of two parts, conoid and trapezoid. The trapezoid part is attached, below to the upper surface of the coracoid process, and above to the trapezoid line on the inferior surface of the lateral part of the clavicle. The conoid part is attached, below to the root of the coracoid process just lateral to the scapular notch. It is attached above to the inferior surface of the clavicle on the conoid tubercle. Movement of the shoulder girdle. Movements at the two joints of the girdle are always associated with the movements of the scapula, Figs 10.2a to f. The movements of the scapula may or may not be associated with the movements of the shoulder joint. The various movements of shoulder girdle are described below. Elevation of the scapula, as in shrugging the shoulders. The movement is brought about by the upper fibers of the trapezius and by the levator scapulae. It is associated with the elevation of the lateral end, and depression of the medial end of the clavicle. The clavicle moves round an anteroposterior axis formed by the costoclavicular ligament, Fig 10.2a. Depression of the scapula, drooping of the shoulder. It is brought about by gravity, and actively by the lower fibers of the serratus anterior and by the pectoralis minor. It is associated with the depression of the lateral end, and elevation of the medial end of the clavicle, Fig 10.2b. Movement A and B occur in inferolateral compartment. See protraction of the scapula, as in pushing and punching movements. It is brought about by the serratus anterior and by the pectoralis minor. It is associated with forward movements of the lateral end and backward movement of the medial end of the clavicle, Fig 10.2c. Retraction of the scapula, squaring the shoulders, is brought about by the rhomboids and by the middle fibers of the trapezius. It is associated with backward movement of the lateral end and forward movement of the medial end of the clavicle, Fig 10.2d. Movements, C, and D, occur in supromedial compartment. Lateral or forward rotation of the scapula round the chest wall takes place during overhead abduction of the arm. The scapula rotates around the coracoclavicular ligaments. The movement is brought about by the upper fibers of the trapezius and the lower fibers of the serratus anterior. This movement is associated with rotation of the clavicle around its long axis, Fig 10.2e. Medial or backward movement of the scapula occurs under the influence of gravity, although it can be brought about actively by the levator scapulae and the rhomboids, Fig 10.2f. Movements, E, and F, occur in inferolateral compartment. Ligaments of the scapula. The coracoacromial ligament, see Fig 7.8. It is a triangular ligament, the apex of which is attached to the tip of the acromion, and the base to the lateral border of the coracoid process. The acromion, the coracoacromial ligament and the coracoid process, together form the coracoacromial arch, which is known as the secondary socket for the head of the humerus. It adds to the stability of the joint and protects the head of the humerus. The suprascapular ligament, it converts the scapular notch into a foramen. The suprascapular nerve passes below the ligament, and the suprascapular artery and vein above the ligament, Fig 10.3. The spinoglenoid ligament, it is a weak band which bridges the spinoglenoid notch. The suprascapular nerve and vessels pass beneath the arch to enter the infraspinous fossa. Dissection. Having studied all the muscles at the upper end of the scapula, it is wise to open and peep into the most mobile shoulder joint. Identify the muscles attached to the greater and lesser tubercles of humerus. Deep to the acromion look for the subacromial bursa. Identify coracoid process, acromion process, and triangular coracoacromial arch binding these two bones together. Trace the supraspinatus muscle from supraspinous fossa of scapula to the greater tubercle of humerus. On its way it is intimately fused to the capsule of the shoulder joint. In the same way, tendons of infraspinatus and teres minor also fuse with the posterior part of the capsule. Inferiorly trace the tendon of long head of triceps brachii from the infraglenoid tubercle of scapula. Cut through the subscapularis muscle at the neck of scapula. It also gets fused with the anterior part of capsule of the shoulder joint as it passes to the lesser tubercle of humerus. Having studied the structures related to shoulder joint, the capsule of the joint is to be opened. Type. The shoulder joint is a synovial joint of ball and socket variety. The articular surface, ligaments, bursae related to this important joint are explained below. Articular surface. The joint is formed by articulation of the glenoid cavity of scapula and the head of the humerus. Therefore, it is also known as the glenohumeral articulation. Structurally, it is a weak joint because the glenoid cavity is too small and shallow to hold the head of the humerus in place. The head is 4 times the size of the glenoid cavity. However, this arrangement permits great mobility. Stability of the joint is maintained by the following factors. 1. The coracoacromial arch or secondary socket for the head of the humerus, see Fig 6.8, the musculotendinous cut of the shoulder. 2. The glenoidal labrum, Latin lip, helps in deepening the glenoid fossa. Stability is also provided by the muscles attaching the humerus to the pectoral girdle, the long head of the biceps brachii, the long head of the triceps brachii. Atmospheric pressure also stabilizes the joint. Ligaments. L. The capsular ligament, it is very loose and permits free movements. It is least supported inferiorly where dislocations are common. Such a dislocation may damage the closely related axillary nerve, see Fig 6.12. Medially, the capsule is attached to the scapula beyond the supraglenoid tubercle and the margins of the labrum. Laterally, it is attached to the anatomical neck of the humerus with the following exceptions. Inferiorly, the attachment extends down to the surgical neck. Superiorly, it is deficient for passage of the tendon of the anteriorly. The capsule is reinforced by supplemental bands called the superior, middle, and inferior glenohumeral ligaments. The area between the superior and middle glenohumeral ligament is a point of weakness in the capsule, foramen of Whitebrecht, which is a common site of anterior dislocation of humeral head. The capsule is lined with synovial membrane. An extension of this membrane forms a tubular sheath for the tendon of the long head of the biceps brachii. 2. The coracohumeral ligament, it extends from the root O1 the coracoid process to the neck of the humerus opposite the greater tubercle. It gives strength to the capsule. 3. Transverse humeral ligament, it bridges the upper part of the bicipital groove of the humerus, between the greater and lesser tubercles. The tendon of the long head of the biceps brachii passes deep to the ligament. 4. The glenoidal labrum, it is a fibrocartilaginous rim which covers the margins of the glenoid cavity, thus increasing the depth of the cavity. Bursae related to the joint. 1. The subacromial, subdeltoid. 2. The subscapularis bursa communicates with joint cavity. 1. The infraspinatus bursa, may communicate with the joint cavity. The subacromial bursa and the subdeltoid bursae are commonly continuous with each other but may be separate. Collectively they are called the subacromial bursa, which separates the acromion process and the coracoacromial ligaments from the supraspinatus tendon and permits smooth motion. Any failure of this mechanism can lead to inflammatory conditions of the supraspinatus tendon. Relation superiorly, coracoacromial arch, subacromial bursa, supraspinatus and deltoid, Fig 10.4. Inferiorly, long head of the triceps brachii, axillary nerves, and posterior circumflex humeral artery. Anteriorly, subscapularis, coracobrachialis, short head O1 biceps brachii and deltoid. Posteriorly, infraspinatus, teres minor, and deltoid. Medially, tendon of the long head of the biceps brachii. Blood supply. 1 anterior circumflex humeral vessels. 2 posterior humeral vessels. 3 suprascapular vessels. 4 subscapular vessels. Nerve supply. 1 axillary nerve. 2 musculocutaneous nerve. 3 suprascapular nerve. Movements of shoulder joint. The shoulder joint enjoys great freedom of mobility at the cost of stability. There is no other joint in the body which is more mobile than the shoulder joint. This wide range of mobility is due to laxity of its fibrous capsule, and the 4 times large size of the head of the humerus as compared with the shallow glenoid canidi. The range of movements is further increased by concurrent movements of the shoulder girdle, Figs 10.5a and b and 10.6a to f. However, this large range of motion makes glenohumeral joint more susceptible to dislocations, instability, degenerative changes and other painful conditions, especially in individuals who perform repetitive overhead motions, cricketers. Movements of the shoulder joint are considered in relation to the scapula rather than in relation to the sagittal and coronal planes. When the arm is by the side, in the resting position, the glenoid cavity faces almost equally forwards and laterally, and the head of the humerus faces medially and backwards. Keeping these directions in mind, the movements are analyzed as follows. 1. Flexion and extension. During flexion the arm moves forwards and medially, and during extension the arm moves backwards and laterally. Thus flexion and extension take place in a plane parallel to the surface of the glenoid cavity, Figs 10.6a and b. 2. Abduction and adduction take place at right angles to the plane of flexion and extension, i.e. approximately midway between the sagittal and coronal planes. In abduction, the arm moves anterolaterally away from the trunk. This movement is in the same plane as that of the body of the scapula, Figs 10.6c and d. 3. Medial and lateral rotations are best demonstrated with a mid-flexed elbow. In this position, the hand is moved medially across the chest in medial rotation, and laterally in lateral rotation of the shoulder joint, Figs 10.6e and f. 4. Circumduction is a combination of different movements as a result of which the hand moves along a circle. The range of any movement depends on the availability of an area of free articular surface on the head of the humerus. Muscles bringing about movements at shoulder joint are shown in Table 10.1. Abduction has been analyzed. Analysis of the overhead movement of the shoulder. The overhead movements of flexion and abduction of the shoulder are brought about by smooth and coordinate motion at all joints of the shoulder complex, glenohumeral, sternoclavicular, acromioclavicular, and scapulothoracic. Only glenohumeral joint motion cannot bring about the 180 degrees of movement that takes place in overhead shoulder movements. The scapula contributes to overhead flexion and abduction by rotating upwardly by 50-60 degrees. The glenohumeral joint contributes 100-120 degrees of flexion and 90-120 degrees of abduction to the total 170-180 degrees of overhead movements. This makes the overall ratio of 2 degree of motion of shoulder to 1 degree of scapulothoracic motion and is often referred to as scapulohumeral rhythm. This for every 15 degrees of elevation, 10 degrees occur at shoulder joint and 5 degrees are due to movement of the scapula. The humeral head undergoes lateral rotation at around 90 degrees of abduction to help clear the greater tubercle under the acromion. Although deltoid is the main abductor of the shoulder, the rotator muscles, namely the supraspinatus, iral raspinatus, teres minor and the subscapularis play a very important role in providing static and dynamic stability to the head of the humerus. Thus the deltoid and these 4 muscles constitute a couple which permits true abduction in the plane of the body of the scapula. In addition, the scapular muscles such as trapezius, serratus anterior, levator scapulae and rhomboids provide stability and mobility to the scapula in the coordinated overhead motion. Serratus anterior is chiefly inserted into the inferior angle of scapula. It rotates this angle laterally. At the same time, trapezius rotates the medial border at root of spine of scapula downwards. The synergic action of these two muscles turns the glenoid cavity upwards, increasing the range of abduction at the shoulder joint. The clavicle may be dislocated at either of its ends. At the medial end, it is usually dislocated, prevented by the costoclavicular ligament. The main bond of union between the clavicle and the manubrium is the articular disc. Apart from its attachment to the joint capsule, the disc is also attached above to the medial end of the clavicle, and below to the manubrium. This prevents the sternal end of the clavicle from tilting upwards when the weight of the arm depresses the acromial end, Fig 10.1. The clavicle dislocates upwards at the acromioclavicular joint, because the clavicle overrides the acromion. The weight of the limb is transmitted from the scapula to the clavicle through the coricoclavicular ligament, and from the clavicle to the sternum through the sternoclavicular joint. Some of the weight also passes to the first rib by the costoclavicular ligament. The clavicle usually fractures between these two ligaments, Fig 10.1. Dislocation. The shoulder joint is more prone to dislocation than any other joint. This is due to laxity of the capsule and the disproportionate area of the articular surfaces. Dislocation usually occurs when the arm is abducted. In this position, the head of the humerus presses against the lower unsupported part of the capsular ligament. Thus almost always the dislocation is primarily subglenoid. Dislocation endangers the axillary nerve, which is closely related to the lower part of the joint capsule, see Fig 6.12. Optimum attitude. In order to avoid ankylosis, many diseases of the shoulder joint are treated in an optimum position of the joint. In this position, the arm is abducted by 45-90 degrees. Shoulder tip poor. Irritation of the peritoneum underlying diaphragm from any surrounding pathology causes referred pain in the shoulder. This is so because the phrenic nerve carrying impulses from peritoneum and the supraclavicular nerves, supplying the skin over the shoulder, both arise from spinal segments C3, C4, Figs 10.7a and b. The shoulder joint is most commonly approached, surgically, from the front. However, for aspiration the needle may be introduced either anteriorly through the deltopectoral triangle, closer to the deltoid, or laterally just below the acromion, Fig 10.8. Frozen shoulder. This is a common occurrence. Pathologically, the two layers of the synovial membrane of the glenohumeral joint is reduced. The patient shows altered scapulohumeral rhythm due to excessive use of scapular motion while performing overhead flexion and abduction. The surrounding muscles show disuse atrophy. The disease is self-limiting and the patient may recover spontaneously in about 2 years and much earlier by physiotherapy. Shoulder joint disease can be excluded if the patient can raise both his arms above the head and bring the two palms together, Fig 10.9. Deltoid muscle and axillary nerve are likely to be intact. Dancing shoulder. When one flexes the arm at shoulder joint, there is one small point which you must remember: whether it is July or November there is a gamble of two muscles, pectoralis major and anterior deltoid, in the tussles. To teres major, latissimus dorsi was happily married, but while extending, these got joined with posterior deltoid. In adduction, of course, the joint decided a better course. It went off with two majors, pectoralis major and teres major. On the way they stopped for some gazers. The two majors danced with subscapularis during medial rotation. Even anterior deltoid and latissimus dorsi soon join the happy flirtation. If one wants the joint to laterally rotate, then there is difference in the male. Posterior deltoid dances with infraspinatus. Even teres minor comes and triangulates. When just abduction is desired, supraspinatus and mid-deltoid are required. But if couple dev has to do the bowling, come trapezius and serratus anterior following. Small muscles provide stability. Large ones give it mobility. And shoulder joint dances, and dances. Dissection. Cut through the muscles arising from the lateral and medial epicondyles of humerus and reflect them distally if not already done. Also cut through biceps brachii, brachialis, and triceps brachii 3 cm proximal to the elbow joint and reflect them distally. Remove all the muscles fused with the fibrous capsule of the elbow joint and define its attachments. Features. The elbow joint is a hinge variety of synovial joint between the lower end of humerus and the upper ends of radius and ulna bones. Elbow joint is the term used for humeroradial joint. The term elbow complex also included the superior radio-ulnar joint also. Articular surfaces upper, the capitulum and trochlea of the humerus. The coronoid fossa lies just above the trochlea and is designed in a manner that the coronoid process of ulna fits into it in extreme flexion. Similarly, the radial fossa just above the capitulum flows for radial head fitting in the radial fossa in extreme flexion. Lower, upper surface of the head of the radius articulate with the capitulum. Trochlear notch of the ulna articulates with the trochlea of the humerus, Fig 10.10. The elbow joint is continuous with the superior radio-ulnar joint. The humeroradial, the humerulnar and the superior radio-ulnar joints are together known as cubital articulations. Ligaments. 1 capsular ligament, superiorly, it is attached to the lower end of the humerus in such a way that the capitulum, the trochlea, the radial fossa, the coronoid fossa and the olecranon fossa are intracapsular. Inferomedially, it is attached to the margin of the trochlear notch of the ulna except laterally. Inferolaterally, it is attached to the annular ligament of the superior radio-ulnar joint. The synovial membrane lines the capsule and the fossae, named above. The anterior ligamentelle, and the posterior ligament are thickening of the capsule. 2. The ulnar collateral ligament is triangular in shape, Fig 10.11. Its apex is attached to the medial 3 epicondyle of the humerus, and its base to the ulna. The ligament has thick anterior and posterior bands, these are attached below to the coronoid process and the olecranon process respectively. Their lower ends are joined to each other by an oblique band which gives attachment to the thinner intermediate fibers of the ligament. The ligament is crossed by the ulnar nerve and it gives origin to the flexor digitorum superficialis. It is closely related to the flexor carpi ulnaris and the triceps brachii. 4. The radial collateral organ lateral ligament, it is a fan-shaped band extending from the lateral epicondyle to the annular ligament. It gives origin to the supinator and to the extensor carpi radialis brevis, Fig 10.12. Relations. Anteriorly, brachialis, median nerve, brachial artery, and tendon of biceps brachii, see Fig 9.4. Posteriorly triceps brachii and anconus. Medially, ulnar nerve, flexor carpi ulnaris and common flexors. Laterally, supinator, extensor carpi radialis brevis and other common extensors. Blood supply from anastomoses around the elbow joint, SRE Fig 8.10. Nerve supply. The joint receives branches from the following nerves. Ulnar nerve, median nerve, and radial nerve. Musculocutaneous nerve through its branch to the brachialis. Movements. 1. Flexion is produced by brachialis biceps brachii and brachioradialis. 2. Extension is produced by triceps brachii and anconus. Carrying angle. The transverse axis of the elbow joint is directed medially and downwards. Because of this, the extended forearm is not in straight line with the arm, but makes an angle of about 13 degrees with it. This is known as the carrying angle. The factors responsible for formation of the carrying angle are as follows. The medial flange of the trochlea is 6 mm deeper than the lateral flange. The superior articular surface of the coronoid process of the ulna is placed oblique to the long axis of the bone. The carrying angle disappears in full flexion or the elbow, and also during pronation of the forearm. The forearm comes into line with the arm in the mid-prone position, and this is the position in which the hand is mostly used. This arrangement of gradually increasing carrying angle during extension of the elbow increases the precision with which the hand, and objects held in it, can be controlled, Fig 10.13. Clinical anatomy: distension of the elbow joint by an effusion occurs posteriorly because here the capsule is weak and the covering deep fascia is thin. Aspiration is done posteriorly on any side of the olecranon, Fig 10.14. Dislocation of the elbow is usually posterior, and is often associated with fracture of the coronoid process. The triangular relationship between the olecranon and the two humeral epicondyles is lost, see Fig. 2.19. Subluxation of the head of the radius, pulled elbow, occurs in children when the forearm is suddenly pulled in pronation. The head of the radius slips out from the annular ligament, see Fig. 2.29. Tennis elbow, occurs in tennis players. Abrupt pronation with fully extended elbow may lead to pain and tenderness over the lateral epicondyle, which gives attachment to common extensor origin, Fig. 10.15. This is possibly due to a sprain of radiocollateral ligament, tearing of fibers of the extensor carpi radialis brevis. Recent researches have pointed out that it is more of a degenerative condition rather than inflammatory condition. Students, mixers, elbow is characterized by effusion into the bursa over the subcutaneous posterior surface of the olecranon process. Students during lectures support their head, for sleeping, with their hands with flexed elbows. The bursa on the olecranon process gets inflamed, Fig. 10.16. Golfer's elbow is the microtrauma of medial epicondyle of humerus, occurs commonly in golf players. The common flexor origin undergoes repetitive strain and results in a painful condition on the medial side of the elbow, Fig. 10.17. If carrying angel, normal is 15, is more, the condition is cubitus valgus, ulnar nerve may get stretched leading to weakness of intrinsic muscles of hand. If the angle is less it is called cubitus varus, Fig. 10.18. Under optimal position of the elbow, generally elbow flexion between 30 and 40 degrees is sufficient to perform common activities of daily living such as eating, combing, dressing, etc. Because of this reason even people who have lost terminal flexion or extension alter a fracture/trauma are able to accomplish these personal tasks without much problems. Radio-ulnar joints. Dissection. Remove all the muscles covering the adjacent sides of radius, ulna, and the intervening interosseous membrane. This will expose the superior and inferior radio-ulnar joints including the interosseous membrane. Cut through the annular ligament to see the superior radio-ulnar joint. Clean and define the interosseous membrane. Lastly, cut through the capsule of inferior radio-ulnar joint to locate the intra-articular fibrocartilaginous disc of the joint. Learn the movements of supination and pronation on dry bones and on yourself. Features. The radius and the ulna are joined to each other at the superior and inferior radio-ulnar joints. These are described in Table 10.2. The radius and ulna are also connected by the interosseous membrane which constitutes middle radio-ulnar joint, Fig. 10.19. Interosseous membrane. The interosseous membrane connects the shafts of the radius and ulna. It is attached to the interosseous borders of these bones. The fibers of the membrane run downwards and medially from the radius to ulna, Fig. 10.19. The two bones are also connected by the oblique cord which extends from the tuberosity of the radius to the tuberosity of the ulna. The direction of its fibers is opposite to that in the interosseous membrane. L superiorly, the interosseous membrane begins 2-3 cm below the radial tuberosity. Between the oblique cord and the interosseous membrane there is a gap for passage of the posterior interosseous vessels to the back of the forearm. 2 inferiorly, a little above its lower margin, there is an aperture for the passage of the anterior interosseous vessels to the back of the forearm. 3. The anterior surface is related to the flexor pollicis longus, the flexor digitorum profundus, the pronator quadratus, and to the anterior interosseous vessels and nerve, see Fig. 2.25. 4. The posterior surface, see Fig. 9.55, is related to the supinator, the abductor pollicis longus, the extensor pollicis brevis, the extensor pollicis longus, the extensor indicis, the anterior interosseous artery and the posterior interosseous nerve. The interosseous membrane performs the following functions. It binds the radius and ulna to each other. It provides attachments to many muscles. It transmits forces, including weight, applied to the radius, through the hand, to the ulna. This transmission is necessary as radius is the main bone taking part in the wrist joint, while the ulna is the main bone taking part in the elbow joint, see Fig 1.2 and Flowchart 1.1. Supination and pronation. Supination and pronation are rotatory movements of the forearm/hand around a vertical axis. In a semi-flexed elbow, the palm is turned upwards in supination, and downwards in pronation, king's pronate, beggar's supinate. The movements are permitted at the superior and inferior radio-ulnar joints. The vertical axis of movement of the radius passes through the center of the head of the radius above, and through the ulnar attachment of the articular disc below, Fig 10.19. However, this axis is not stationary because the lower end of the ulna is not fixed, it moves backwards and laterally during pronation, and forwards and medially during supination. As a result of this movement, the axis, defined above, is displaced laterally in pronation, and medially in supination. Supination is more powerful than pronation because it is an anti-gravity movement. Supination movements are responsible for all screwing movements of the hand, e.g. as in tightening nuts and bolts. Morphologically, pronation and supination were evolved for picking up food and taking it to the mouth. Around 50° of supination and 50° of pronation is generally required to perform many of the routine activities. Pronation is brought about chiefly by the pronator quadratus. It is aided by the pronator teres when the movement is rapid and against resistance. Gravity also helps, Fig 10.21. Supination is brought about by the supinator muscle and the biceps brachii. Slow supination, with elbow extended, is done by the supinator. Rapid supination with the elbow flexed, and when performed against resistance, is done mainly by the biceps brachii, Fig 10.22. Clinical anatomy. Supination and pronation. During supination the radius and ulna are parallel to each other. During pronation radius crosses over the ulna, Figs 10.23a and b. In synostosis, fusion, of upper end of radius and ulna, pronation is not possible. Wrist, radiocarpal, joint. Dissection. Cut through the thenar and hypothenar muscles from their origins and reflect them distally. Separate the flexor and extensor reticula of the wrist from the bones. Cut through flexor and extensor tendons, if not already done, and reflect them distally. Define the capsular attachments and ligaments and relations of the wrist joint. Type. Wrist joint is a synovial joint of the ellipsoid variety between lower end of radius and articular disc of inferior radio-ulnar joint proximally and three lateral bones of proximal row of carpus, i.e. scaphoid, lunate, and triquetra distally. The pisiform does not play a role in the radiocarpal articulation. It is a sesamoid bone acting as a pulley for flexor carpi ulnaris, articular surfaces upper, one inferior surface of the lower end of the radius. 2 articular disc of the inferior radio-ulnar joint. Lower scaphoid lunate and triquetra bones. Ligaments. 1. The articular capsule surrounds the joint. It is attached above to the lower ends of the radius and ulna, and below to the proximal row of carpal bones. A protrusion of synovial membrane, called the prestyloid recess, lies in front of the styloid process of the ulna and in front of the articular disc. It is bounded inferiorly by a small meniscus projecting inwards from the ulnar collateral ligament between the styloid process and the triquetra bone. The fibrous capsule is strengthened by the following ligaments. 2. On the pulvinar aspect, there are 2 pulvinar carpal ligaments. The pulvinar radiocarpal ligament is a broad band. It begins above from the anterior margin of the lower end of the radius and its styloid process, runs downwards and medially, and is attached below to the anterior surfaces of the scaphoid, the lunate and triquetra bones. The pulvinar ulnocarpal ligament is a rounded fasciculus. It begins above from the base of the styloid process of the ulna and the anterior margin of the articular disc, runs downwards and laterally, and is attached to the lunate and triquetra bones. Both the pulvinar carpal ligament are condited to be intracapsular. 3. On the dorsal aspect of the joint, there is one dorsal radiocarpal ligament. It is weaker than the pulvinar ligaments. It begins above from the posterior margin of the lower end of the radius, runs downwards and medially, and is attached below to the dorsal surfaces of the scaphoid, lunate and triquetra bones, Fig 10.25. 4. The radial collateral ligament extends from the tip of the styloid process of the radius to the lateral side of the scaphoid bone, Fig 10.24. It is related to the radial artery. The ulnar collateral ligamenti extends from the tip of the styloid process of the ulna to the triquetra and pisiform bones. Both the collateral ligaments are poorly developed. Anterior long flexor tendon with their synovial sheath and median nerve. Posterior extensor tendon of the wrist and fingers with their synovial sheaths. Lateral radial artery. Blood supply, anterior and posterior carpal arches. Nerve supply. Anterior and posterior interosseous nerves. Movements. Movements at the radiocarpal joints are accompanied by movements at the midcarpal joint. The midcarpal joint is anatomically separate from radiocarpal joint. The joint between the two rows of carpal bones does not have smooth joint line because of multiple small joints. However, it still behaves as a functional unit in all movements of the wrist joint. In addition to the congruency and the shape of the articular surfaces of radius and carpal bones, the length of the ulna can also affect the amount of motion available at the wrist joint. In the ulnar negative variance, the distal end of ulna is shorter than the radius and vice versa in ulnar positive variance. The wrist joint has the following movements. 1. Flexion, it takes place more at the midcarpal than at the wrist joint. The main flexors are, I. Flexor carpi radialis. 2. Flexor carpi ulnaris. 3. Palmaris longus. The movement is assisted by long flexors of the fingers and thumb, Fig 10.34, and abductor pollicis longus. 2. Extension, it takes place mainly at the wrist joint. The main extensors are, extensor carpi radialis longus, extensor carpi radialis brevis, extensor carpi ulnaris. It is assisted by the extensors of the fingers and thumb, Fig 10.27. 3. Abduction, radial deviation, it occurs mainly at the midcarpal joint. The main abductors are, flexor carpi radialis, extensor carpi radialis longus and extensor carpi radialis brevis. Abductor pollicis longus and extensor pollicis brevis. 4. Adduction, ulnar deviation, it occurs mainly at the wrist joint. The main adductors are, flexor carpi ulnaris, extensor carpi ulnaris. 5. Circumduction, the range of flexion is more than that of extension. Similarly, the range of adduction is greater than abduction, due to the shorter styloid process of ulna. Wrist joint and interphalangeal joints are commonly involved. And rheumatoid arthritis, Figs 10.28a and b. The back of the wrist is the common site for a ganglion. It is a cystic swelling resulting from mucoid degeneration of synovial sheaths around the tendons, Fig 10.29. The wrist joint can be aspirated from the posterior surface between the tendons of the extensor pollicis longus and the extensor digitorum, Fig 10.30. The joint is immobilized in optimum position of 30 degrees dorsiflexion, extension. Because of the complex nature of the joint and the multiple articulations, any injury to the ligaments attached to the proximal or the distal row of carpal bones may cause subluxation of the carpals ventrally or dorsally, leading to painful condition of the wrist. Dissection. Out of these, the most important joint with a separate joint cavity is the first carpometacarpal joint. This is the joint of the thumb, and a wide variety of functionally useful movements take place here. Identify the distal surface of trapezium and base of first metacarpal bone. Define the metacarpophalangeal and interphalangeal joints. For their dissection, remove all the muscles and tendons from the anterior and posterior aspects of any two metacarpophalangeal joints. Define the articular capsule and ligaments. Do the same for proximal and distal interphalangeal joints of one of the fingers and define the ligaments. Intercarpal, carpometacarpal, and intermetacarpal joints. There are 3 joint cavities among the intercarpal, carpometacarpal, and intermetacarpal joints, which are 1 pisa triquetra. 3 first carpometacarpal. 1 a common cavity for the rest of the joints. The common cavity may be described as the midcarpal, transverse intercarpal, joint between the proximal and distal rows of the carpus, which communicates with intercarpal joints superiorly, and with intercarpal, carpometacarpal, and intermetacarpal joints inferiorly, Fig 10.24. The midcarpal joint permits movements between the 2 rows of the carpus as already described with the wrist joint. First carpometacarpal joint. First carpometacarpal joint is only carpometacarpal joint which has a separate joint cavity. Movements at this joint are, therefore, much more free than at any other corresponding joint. Type saddle variety of synovial joint, because the articular surfaces are concavo-convex. Articular surfaces. I. The distal surface of the trapezium. 2. The proximal surface of the base of the first metacarpal bone. The articulating surface of trapezium is concave in the sagittal plane and convex in the frontal plane. The concavo-convex nature of the articular surfaces permits a wide range of movements, Fig 10.24. Ligaments. 1 capsular ligament surrounds the joint. In general, it is thick but loose, and is thickest dorsally and laterally. 2. Lateral ligament is broad band which strengthens the capsule laterally. 3. The anterior ligament. 4. The posterior ligaments are oblique bands running downwards and medially. Relations. Anteriorly, the joint is covered by the muscles of the thenar eminence, see Figs 9.22. Posteriorly, long and short extensors of the thumb, Figs 10.32a and b. Medially, first dorsal interosseous muscle, and the radial artery, passing from the dorsal to the pulvinar aspect of the hand through the interosseous space. Laterally, tendon of the abductor pollicis longus. Blood supply. Radial vessels supply blood to the synovial membrane and capsule of the joint. Nerve supply. First digital branch of median nerve supplies the capsule of the joint. Movements. Flexion and extension of the thumb take place in the plane of the palm, and abduction and adduction at right angles to the plane of the palm. In opposition, the thumb crosses the palm and touches other fingers. Flexion is associated with medial rotation, and extension with lateral rotation at the joint. Circumduction is a combination of different movements mentioned. The following muscles bring about the movements, Figs 10.31a to 10.32b. The opposition is a sequential movement of abduction, flexion, adduction of the first metacarpal with simultaneous rotation. Opposition is unique to human beings and is one of the most important movements of the hand considering that this motion is used in almost all types of gripping actions. The adductor pollicis and the flexor pollicis longus exert pressure on the opposed fingers. The first carpometacarpal joint can undergo degenerative changes with age, which is a painful condition of the base of the thumb. The synovial lining of the tendons of extensor pollicis brevis and abductor pollicis longus can get inflamed due to repetitive strain and can lead to a painful condition called decay or veins tenosynovitis. Movement of the thumb can aggravate pain in this condition. Metacarpophalangeal joints. Type metacarpophalangeal joints are synovial joints of the ellipsoid variety. Ligaments. Each joint has the following ligaments. 1 capsular ligament, this is thick in front and thin behind. 2 pulvinar ligament, this is a strong fibrocartilaginous plate which replaces the anterior part of the capsule. It is more firmly attached to the phalanx than to the metacarpal. The various pulvinar ligaments of the metacarpophalangeal joints are joined to one another by the deep transverse metacarpal ligament. 3 medial and lateral collateral ligaments, these are oblique bands placed at the sides of the joint. Each runs downwards and forwards from the head of the metacarpal bone to the base of the phalanx. These are taut in flexion and relaxed in extension. Movements at first joint and muscles producing them. Flexion flexor pollicis longus and flexor pollicis brevis. 1 extension, extensor pollicis longus and extensor pollicis brevis, Figs 10.32a and b, point 2 abduction abductor pollicis brevis. 2-3 adduction adductor pollicis. Movements at 2nd to 5th joints and muscles producing them. 1 flexion, interossei and lumbricals, see Figs 9.21 and 9.23. 2 extension extensor of the fingers. 3 abduction dorsal interossei. 4 adduction pulvinar interossei. 5 circumduction above muscles in sequence. Interphalangeal joints, proximal and distal. Type. Herc varied of Synovia 1 joints, Fig 10.33. Ligaments. Similar to the metacarpophalangeal joints, that is 1 pulvinar fibrocartilaginous ligament and 2 collateral bands running downwards and forwards. Movements at interphalangeal joint of thumb. Flexion, flexor pollicis longus. Extension, extensor pollicis longus. Movements at 2nd to 5th digits. L flexion. Flexor digitorum superficialis at the proximal interphalangeal joint, and the flexor digitorum profundus at the distal joint, Fig 10.34. 2 extension interossei and lumbricalis. Segmental innervation of movements of upper limb. Figures 10.35a to I shows the segments of the spinal cord responsible for movements of the various joints or the upper limb. The proximal muscles of upper limb are supplied by proximal nerve roots forming brachial plexus and distal muscles by the distal or lower nerve roots. In shoulder, abduction is done by muscles supplied by C5 spinal segment and adduction by muscles innervat by C6, C7 spinal segment. Elbow joint is flexed by C5, C6 and extended by C7, C8 innervat muscles. Supination is caused by muscle innervated by C6 spinal segment. Even pronation is done through C6 spinal segment. Extension and flexion of wrist is done through C6, C7 spinal segments. Both the pulvinar and dorsal interossei are innervat by Th1 spinal segment. The interphalangeal joints also are flexed and extended by same spinal segments, i.e. C7, C8. Sternoclavicular joint is a saddle variety of synovial joint. Its cavity is divided into 2 parts by an articular disc. Movements of shoulder girdle help the movements of shoulder joint during 90° 180° abduction. Shoulder joint is freely mobile and is vulnerable to dislocation. Ulnar nerve lies behind medial epicondyle. It is not a content of the cubital fossa. Carrying angle separates the wrist from the hip joint while carrying buckets, etc. Biceps brachii is an important supinator of forearm when the elbow is flexed. Kings pronate while beggars supinate. Movements of pronation and supination are not occurring at the elbow or WRLST joints. First, carpometacarpal joint is the most important joint as it permits the thumb to oppose the palm/fingers for holding things. Shoulder joint commonly dislocates inferiorly. Ulnar nerve lies behind medial epicondyle, pressing the nerve cause tingling sensation. That is why the bone is named humerus. Giving is pronation, receiving is supination. Picking up food with digits is pronation, putting it in the mouth is supination. Axis of movements of abduction and adduction of fingers is through the center of the middle finger.